Hello, everyone. My name is Shanlee Davis, and I am a pediatric endocrinologist at the Extraordinary Kids Clinic at Children's Hospital, Colorado. I'm excited to talk to you today about fertility and ovarian function in trisomy X syndrome. So first, to start off, let's review the female reproductive system. We're talking today about the ovaries, which are responsible for storing and releasing eggs, which we also call oocytes, as well as producing reproductive hormones, primarily estrogen and progesterone, although we'll be talking about another important hormone the ovaries make as well. Did you know that when girls are born, they have over 2 million oocytes or eggs, but they continuously mature and die off even before they start puberty. So by the time puberty starts, they only have about 400,000 eggs left. When all of the eggs are gone, a woman enters menopause and periods stop happening and they no longer have any fertility potential. So let's spend a minute to review what normal puberty is and what normal reproductive cycles are for women. So breast buds can start anywhere between age 8 and 13 years. On average, they start about 10 and a half years. Pubic hair starts around the same time, on average at 11 years of age. And girls have their first period on average at 12 and a half years of age, but anywhere from 9 to 15 can be normal. Periods can be irregular for the first 1 to 2 years of life, and then they should start to have some more consistency. Typically, women have periods every 21 to 40 days, on average 28-day cycles. It's normal as long as you're having at least 8 periods a year, but less than that is abnormal. Periods typically stop once a woman is around age 50. Anywhere from 45 to 55 can be normal age of menopause. But some women experience menopause early. This is called premature ovarian failure, sometimes abbreviated POF. If the ovaries lose their function before age 40, this meets the definition for POF. It's also sometimes called POI, or primary ovarian insufficiency. Importantly, women can have POI even if they're still having periods, because if their fertility potential is down, or they have infertility, they may still meet the definition for POI, even if menses are still happening. So why are we talking about POI and trisomy X today? Well, there are many different causes of POI, and some of them are genetic. Frequently known ones are Turner syndrome and Fragile X premutation, but trisomy X is also a known cause of premature ovarian insufficiency. 1 to 4% of women, all women with POI, have trisomy X, depending upon what studies you look at. And this is sometimes how women are identified to have trisomy X during an infertility workup. There are also many case reports of POI in women with trisomy X, but there are also many successful pregnancies as well. In fact, 8 out of 11 girls with trisomy X in the Denver birth cohort studies from the 1970s ended up getting pregnant by early adulthood, in their teens or 20s. So that's a pretty good percentage. We don't actually know what percent of women with trisomy X have POI, and that's an important research question that we still have yet to answer. And why do we even care? Well, for one, again, the ovaries are really imperative in producing hormones, including estrogen. And the estrogen we can replace through patches or pills. But the ovaries are also essential for fertility. And unfortunately, if this is lost, we can't replace it. So we did a study at the Extraordinary Kids Clinic in Colorado, led by Dr. Nicole Tartaglia, who studied 15 adolescent girls with trisomy X. And what did we learn? Well, 14 out of 15 of them had normal puberty timing. One of them did have delayed puberty, but the majority had normal puberty timing and progression. The average age of their first period was 12 and a half, so this is exactly what we would expect in the general population. And 2/3 of the girls were having irregular periods at the time of this study. The other 1/3 were still within the first couple of years after having their first period, and so it could be normal to still have some irregularity there. When reproductive hormones were checked, including things like estrogen, they were all pretty much normal, except for a hormone called AMH, or anti-Müllerian hormone. So let's pause for a minute and talk about what AMH is. So anti-Müllerian hormone, or AMH, is a hormone that's made by the developing follicles, or eggs, in the ovary during a specific stage of maturation. If you look over here, these are the very early, what we call oocytes, or early eggs. And these are actually already in this stage by the time a girl is born, in this primordial follicle stage. This primordial follicle stage is really what we refer to when we talk about ovarian reserve, or how many, what your fertility potential is, how many eggs you have left. AMH is actually not made by these primordial follicles, but it's made by these follicles in this developing stage here, the primary, secondary, and tertiary follicles. And these then reflect really how many primordial follicles you have left. So although AMH isn't actually measuring these early primordial follicles, it is an estimate of how many primordial follicles are left. So AMH in healthy females can range quite a bit. So this is using a different scale here than what we typically use in the United States to measure AMH. But down here at this bottom line is around 1 nanogram per milliliter, and up here is 8 nanograms per milliliter. This is typically the scale that we're using when we measure AMH in girls and women. So usually in healthy, AMH is going to fall between these levels, on average be around 2 nanograms per deciliter. A couple other take homes is that AMH is pretty constant throughout a woman's reproductive life. Even before they start puberty, you can see here, these are age 4, 5, 6, 7, 8. AMH is pretty consistent in this range. And if you have an AMH around 5, it typically stays around 5 until you enter menopause, and then it declines pretty rapidly over here. Importantly, levels less than 1 nanogram per mil have been shown to be concerning for a low ovarian reserve and a decreased chance of getting pregnant spontaneously. So what did we find when we looked at AMH levels in adolescent girls with trisomy X? Well, adolescent girls with trisomy X are all represented in the black circles here, and girls without trisomy X are controls in the white circles or open circles here. You can see that most of the girls with trisomy X are at or below this 1 nanogram per deciliter, or nanogram per milliliter line. So they are at or below the normal range. There's also no relationship to age. It doesn't seem to be declining over time. In fact, one of the girls not shown here, we had one girl who was 5 years old, and she had an AMH that was less than 1 as well. We also had 4 girls that had repeated AMH levels. 3 of them were below the normal range, and when it was repeated, they stayed below the normal range. One of the girls had an AMH in the normal range up here, and she stayed in that normal range upon repeating. So it seemed to be pretty consistent, although these are very limited and small numbers here. So here's a summary of what we know right now. Girls and women with trisomy X are at risk for premature ovarian insufficiency. However, most girls with trisomy X will go through puberty normally and be fertile. AMH is, as a marker of ovarian reserve, can be easily measured from blood. And at least in our study, we showed that AMH is much lower in girls with trisomy X, but we don't really know why or whether or not this translates to a risk of future premature ovarian insufficiency for sure. So we have a lot more research to do in this area. So what do we do if POI is diagnosed? Well, the easy part for me as an endocrinologist is replacing the hormones that the ovaries are supposed to be making. We know that estrogen is absolutely essential for health. It's essential for brain, both brain development, memory, body temperature, and libido. It's important for your heart, and in particular, levels of cholesterol are regulated by estrogen. It's also important for the liver and the skin and the reproductive hormones, or sorry, the reproductive organs as well. But the most important thing that estrogen is absolutely critical for, particularly during the teenage years, is bone health. Estrogen is increasing or strengthening bone, increasing bone density. And we only have this opportunity to increase bone density up until your mid-20s. After around age 25 or so, your bone density goes downhill. And so whatever you have accrued up until that point is what you have left with for the rest of your life. So low estrogen levels or insufficient estrogen levels during your teenage years and your early 20s can really set you up for osteoporosis lifelong. And that's something that is absolutely essential to address in those early years. We can easily replace estrogen through a patch called transdermal estrogen replacement, or a pill if transdermal is not available or there's problems with it. The transdermal approach to replacing estrogen is preferred if your ovaries aren't making estrogen normally, because it allows that estrogen to go directly into your bloodstream and not have to bypass or go through processing in the liver first. We also need to replace progesterone, and that's important for both systemic reasons, not as much as estrogen, but also because the uterus really depends on progesterone. With estrogen alone, there's an increased risk of uterine cancer if you don't have progesterone to balance that out. So what about the other function of the ovaries? AKA fertility, or being able to have eggs to reproduce. So if for women that are at risk or having infertility or at risk for infertility in the future, there are several different fertility preservation options. This first one on here is embryo cryopreservation. This is the most tried and true. It has the highest success rates, more than 60% success rates. And it has been used the longest. So we have the most experience with this. What embryo cryopreservation is they remove a mature egg from the woman, and they fertilize it with a sperm. And then they save this entire embryo for later. Obviously, you need sperm for this, and a lot of young girls who might be at risk for premature ovarian insufficiency are not at a point where they would have available sperm to be able to undergo embryo cryopreservation. So the next option in here that we have the second to the most experience with is mature oocyte cryopreservation. So this is girls who have already gone through puberty and are already having periods. We can take out those mature eggs through a stimulation process, and they just freeze those mature eggs to be able to be used later, where they'll take them out of the freezer and then insert or fertilize with a sperm later when the woman is ready to have a baby. This is less successful, but still pretty good, and has a lot of evidence behind it and is considered standard of care. Again, you need to have already gone through puberty and be having periods in order to undergo oocyte cryopreservation. I'm not going to talk so much about the immature oocyte cryopreservation because that's not really as relevant to conditions like trisomy X or Turner syndrome or other things that put you at risk for premature ovarian insufficiency, but we don't have necessarily an urgency like there is with cancer and undergoing cancer treatments. So the final one on here is ovarian tissue cryopreservation. This is still considered experimental for conditions like trisomy X or Turner syndrome, where girls have an increased risk of premature ovarian insufficiency. But this process essentially is taking the ovary, either the entire ovary or part of the ovary, and putting the whole thing in the freezer for later. This is a surgical procedure, and it is still considered investigational. There have been pregnancies from this process where they took an ovarian tissue out and then later put it back in when the woman was ready to have babies, but it has not, to my knowledge, been used in trisomy X previously. So this is a little bit about ovarian tissue cryopreservation. This is the surgical procedure in which they actually remove the ovary and they're taking it out, and they're right here taking this ovarian tissue in slices and storing it in the freezer until they're ready to use it in the future. So fertility preservation does not come without a cost. And unfortunately, in a lot of states, this is not a covered cost by insurance. So it's definitely something to consider. The oocyte cryopreservation is the cheapest out of all of these, but that still is $7,000, not including meds. This does not also include the time for freezing. Long-term storage is down at the bottom, usually around $500 a year. And then for oocyte cryopreservation, there's another step that has to happen in the future as well, which is the fertilizing of that oocyte in the future, and putting that embryo then back in to the uterus to have a pregnancy. Ovarian tissue cryopreservation can range quite a lot. If there is an indication for a surgery already, then it might be on the lower side, because the surgical costs are really the most expensive part of that procedure. So definitely a lot of things to consider, particularly that we don't have really any evidence of these specific fertility preservation methods in trisomy X, but we do in other genetic conditions that are at risk for premature ovarian insufficiency. So what are our recommendations on a clinical perspective when we have girls that come to us in the clinic, or parents that are interested in, what should they do for their daughter? So the first thing is making sure that you see an endocrinologist, a pediatric endocrinologist, if puberty hasn't started on time. So if you haven't had breast buds by 13 or started periods by 15, or even getting towards the later side of that timing, it's important to see a pediatric endocrinologist so we can evaluate what the current ovarian function is and whether or not there's anything else that's contributing to delayed puberty. The second thing is after puberty has started and after periods have started, keep track of how often they're occurring. And if they change, again, see an endocrinologist or a gynecologist so that an evaluation can take place so we can understand if their irregular periods are because of a problem with the ovaries and the ovary function. I think that it's probably too premature to universally recommend checking AMH levels because we don't know exactly what they mean in trisomy X, but I think it's worth considering checking and following these AMH levels over time. They can be checked even in infants to look at what the current ovarian function is, although we don't necessarily know for sure if that represents what it will be in 10 years, 20 years down the road. But it gives us an idea and I think helps us prepare for the future. Importantly, if the AMH level is undetectable, like completely gone, this would be suspicious for complete ovarian failure, which would not usually be expected in kids with trisomy X. And if that is happening, I would look for possibly whether or not there is actually a Turner syndrome cell line that might be somewhere in that child, in addition to the trisomy X cell line, if there's absolutely no ovarian function prepubertally. And then I think it's important to learn about what options are available, both now and then as we learn more through research and advancement in fertility preservation technologies, what might be available to girls and women with trisomy X. And then finally, to have age and developmentally appropriate discussions. I think one of the big things that you need to emphasize is that there are lots of different ways to have a family and to be a parent, so that one can be prepared if that is in the future. If infertility is in the future. And the second thing is that emphasizing that ovarian function and fertility does not define gender expression, sexuality. So are very different things. And we have estrogen to replace all of the important functions of those hormones that would be missing. And that is a important point to make when we're bringing up these discussions with individuals that might be affected. And a couple of resources here I just wanted to point out are available on the AXYS website. We published a paper last year on diminished ovarian reserve in girls with trisomy X syndrome, and this goes into more detail about the AMH that I discussed earlier in this talk. And we also did a webinar that is available on the AXYS website as well that talks more about this particular paper. I also encourage you to keep an eye on the AXYS website for future research opportunities that might be available so that we can learn more about ovarian function in girls with trisomy X and women as well. Thank you very much for your time. That is all I have today, and I'm happy to take any questions.